Shall we hear SHREYAS? Then we'll go on. Can you share your screen, SHREYAS?
So at the outset, I would like to thank everyone at ARC for this kind invitation. So today I'll be speaking to you all about some of the critical factors, some of the challenges that we face with the sizing of phakic IOLs and what we need to do. I think everyone in this panel, all my co-speakers, and I'm sure everyone practicing phakic IOL surgery would agree that it is perhaps one of the simplest surgeries that we perform on a daily basis. But the success of the surgery, the complications, the challenges are almost always due to challenges with the preoperative parameters and the measurements that we have taken. While there are a lot of important parameters, some which have already been alluded to, things like sulcus to sulcus, which is possibly very important, which is where actually we are implanting the lens, angle to angle measurements, the angle opening distances, and the lens rise as well. But while these parameters are important and it's nice to know all these factors, unfortunately, even today, white to white and AC depth are perhaps the only two parameters which are taken into the nomogram calculations of most phakic IOL manufacturers even today. The challenges here with regard to phakic IOL challenging is with the phakic IOL implantation is that while we are putting in the lens in the sulcus, we are measuring the white to white, which like Dr. Vardhaman rightly mentioned is a surrogate measure. White to white does not correlate with the sulcus to sulcus diameters, and multiple studies have already shown this. Central AC depth also does not correspond to peripheral AC depth. So while angle more than 30 degrees has been mentioned, we don't have exact nomograms of what a peripheral AC depth should be. All our cutoffs, 2.8, 3 millimeter, whatever you follow, is all dependent on the central AC depth. And we've also seen that a patient can have the same measurement, same white to white, same anterior chamber depth, but have different vault measurements due to various other factors. At the same time, having a similar vault, this patient can have a narrow angle in one patient and a wide open angle in the other patient. So same vault, but different angles. So these are some of the limitations that we have day to day. When it comes to these two critical factors, white to white and AC depth, though, it's the white to white which becomes even more important, because even a 0.2 millimeter variability can cause a shift in the size of lens which has to be selected. Fortunately, with AC depth, the variability is less because the vast majority of our patients are going to fall between the 2.8 to 3.4 AC depth. And for a vast majority, it will not create a significant change in the size. But it's the white to white which becomes even more critical. And with the advent of these Indian lenses, which we have in 0.25 millimeter sizing, where you can just increase it by 0.25 to get your adequate vault, it becomes even more critical to have white to white adequately measured. Anterior chamber depth is important. Most devices measure it very well. Just suffice to say that the ASOCT alone tends to overestimate it a little bit if you're using the caliper, but otherwise most other instruments are quite good. For white to white, digital caliper continues to remain the gold standard. It's cost effective, but the only challenge is the repeatability. This is one study which has been done long back, and has shown that between two inter-observer variation can be as high as 0.5 with regards to the caliper. But with the automated devices like your OrbScan, Pentacam, IOL Master, the differences are much smaller. So it's really time that we started slowly shifting from digital calipers to automated measurements. The challenge with the digital caliper itself is that the white to white measurement depends on identifying the middle of the limbus accurately. Now, when the patient is not does not have a very well pigmented limbus, identifying the middle of the limbus, the blue zone, all of this becomes challenging, and it can definitely lead to errors. The other issue is, unless you're really taking the patient under an operating microscope, just under a slit lamp, you have difficulties in measuring the using the caliper as well. And very often some people resort to just making the patient lie down and doing it under the naked eye. Again, that gives a greater variability in the measurements. Like I already mentioned, AC depth is much more consistent across measurement devices. Only the ASOCT tends to overestimate it. White to white, while the differences are statistically insignificant, you can see this particular paper, all these measurements were told statistically insignificant. But does that mean can they be used interchangeably? When you just look at the mean results of a large number of patients, the mean becomes statistically insignificant. But when you actually look at the variability of the measurement, now a greater than 0.5 millimeter of variability was found in a high number of patients. So this goes on to say that there is a great number of outliers which either exceed or are lower in terms of the measurements, although the mean may not be statistically different. As already mentioned, while S2S might be ideal, it has poor interclass correlation and poor resolution of images with our standard 50 megahertz, which we use. Only the very high frequency, like the Artemis, has been proven to be of some use, but all the standard ultrasound devices that we use for UBMs that we use are not adequate. I'll just quickly run you all through this study, which we did at our center. We used 6 different devices to measure various measurements, white to white, which we use the digital caliper, the Topolyser, the Pentacam, the IOL 700, and the ASOCT. And then also we use the ASOCT and UBM to measure the angle to angle and the UBM with sulcus to sulcus. Now, while we know that angle to angle and sulcus to sulcus are very different from white to white, we were wondering whether we could arrive at an equation which would help us correlate these two measurements in a better way. So the aim was really to find the correlation, but not the difference, and also to derive at an equation to make different white to white values interchangeable. We looked at about 100 patients who were in the refractive surgery age group, and all measurements were done by a trained optometrist or by cornea fellows. If you just look at the mean values, just like in other studies, all the mean values looked very close and looked as if they could be interchangeable. But if you kept the 0.2 millimeter as the variability limit, because anything more than 0.2 millimeter can cause a change in the size of lens that you'll choose, there was a certain high degree of outliers that you could see. With the Topolyser, it was a little lesser. It was more tightly packed. But when we went to Pentacam, it was a lot more spread out, as you can see in this blind ultimate plot. And with the IOL 700, just like in the previous papers with the IOL 500 as well, there was a tendency for overestimation of the white to white as compared to the digital caliper. So we used a simple linear regression and try to arrive at this particular equation, where basically you plug in the value. If let's say X is 12, that is through using your digital caliper, which we used as the gold standard, as 12, then you plug in that value of 12 within this equation to derive the value which you would get through your Pentacam, Topolyser, or IOL Master. We applied this and tried to see what was, how it was making the differences. Now, while I already mentioned Topolyser was quite close to the digital caliper, but in the Pentacam, only 2/3 of patients were within 0.2 millimeter when we looked at direct measurements. But when we included this equation and applied this equation to the values that have been measured, we were able to improve from 66% to 98% of patients which had agreement between the value of digital caliper and
So
Pentacam.
you have 1 minute remaining.
Yeah, I'll close quickly. So this was possibly one of the best things that came out of applying this linear regression, where a Pentacam, which is a commonly available device in most refractive practices, you could now use this equation and be sure that 98% of the time that you would have a great agreement between two devices and not just rely on your manual digital. So as I mentioned, after applying, the values became a lot tighter, and you can see the regression line is a great predictability and great agreement between the devices. We also wanted to analyze why the IOL Master did not work out. While you look at the comparative paired plots of measurements between the manual digital and Topolyser, they are almost all of them are linear. Whereas with the IOL 700, you had these outliers, which are these crisscross lines that you're seeing cutting across. And this was the reason that was attributed why the IOL Master was still not interchangeable, is using the manual digital caliper or the Pentacam and other values. We also tried to look at the white to white and angle to angle, but suffice to say, even after using regression equations, it was not the predictability factor, the R value was very low, and the R square value is very low, and we did not find it conclusive. So white to white repeatability limitations can be overcome by using alternate automated measurements, and the limitations of digital white to white, the inter-observer variability can be reduced. Using linear regression equations will definitely help in improving reliability of the measurements. STS and ATA at this point of time are not reliable measures for predicting phakic IOL sizing. Thank you so much for your kind attention.
Thanks, Shreyas. So I'm going to be asking some 3-4 questions, and Anaga will be asking 2. And although I would be addressing these questions to the expert panel, both Shreyash and Vardhaman, I'm sure you'll have been thorough when you prepared your talks. So I would please want you all to chip in and contradict any of the expert panel when you have a valid reasoning. So the first question which I would want our attendees to know, and I want Kamal Kapoor to look at it, a young practitioner who does not have access to topography for powers which are beyond the scope of laser vision correction. Now, is he justified in doing phakic IOL in these patients when he does not have a topography with him?
Okay, I think this is a very, very useful question for most of the beginner young ophthalmologists. I think the role of topography comes more so when we are looking at, corneal suspects, where we are looking at corneal pathologies. And a lot of times, I think with sheer little bit of experience, you are able to look at some potential corneal abnormalities. Most of these patients who come to us for refractive corrections, more so for the case of medical legal, because when we are doing a refractive procedure on the cornea, that is the time I think corneal topography for a beginner practitioner comes in more handy. But as you said, they are beginning practitioners. They are not probably having their own LASIK machines. So doing a phakic IOL, I think, is far more predictable rather than working on the cornea and firing laser. 2 reasons: because once you are working on the cornea, which is already on the brink of being unstable, you're probably precipitating something which probably was waiting to happen or may not have happened in the near future. And secondly, when you're going for a phakic IOL procedure, you by yourself are not the one who's accelerated the process. So I guess you can work around it, provided you have a keen eye for, power changes, power shifts, shift in cylinders, shift in axis, and if you have an access to a pachymetry, ultrasonic pachymetry. So this can form a little kind of a shell or a helmet around your practice, and you can go ahead. So for a beginner practitioner who wants to get into the refractive practice, still being able to perform a phakic IOL, I think, is far more safer than working on any other corneal procedure. So my answer would be yes. With a relative safety net, a beginner practitioner can go for phakic IOLs, provided he has materials to do his white-to-white measurement, standardized with an anterior chamber depth measured by an ultrasonic immersion pachymeter. So all those things can add on, and there are nomograms for that. They can work on it, yes.
Vardhaman, you have anything to add on this?
Yeah, ma'am. Ma'am, I'll just close my video because my internet is a bit slow. I think I will agree on the point that yes, I mean, in a way, for beginning refractive surgeon, phakic IOL is probably slightly easier to master as compared to the corneal laser procedure. But I'll say in today's times, when we have access to topographies and pentacams very easily, because in majority of the cities now you have actually access in some common centers which are neutral centers. You can also send it to a friend and get back. I think that topography will be required because for your calculations of phakic lenses also you require a very, very accurate keratometry. And also you require a very accurate pachymetry, because even for your internal ACD to be calculated and also for your calculations of the phakic lenses, it should come handy. I think the other methods of anterior chamber depth compared to, I think if we have to really rely, it is better to rely on the internal, which is minus the pachymetry on IOL master, or by doing a tomography rather than ultrasound, because ultrasound has not been seen to be very reproducible. And here we are actually playing on very thin line, because even if we are 2.9 versus 2.7, our decisions can change actually in this. And in the beginning, you require surgeries which are very, very successful, that will give you a lot of confidence, rather than probably going in situations where you can have issues. So I will say that I will still insist that it is a must that they should get a topography done, and they can always get it done from one of their friends' clinic or from a neutral center, but always get it done.
Very valid thoughts, Vardhaman.
I agree with Vardhaman, but the question given is that there is the topography is not there. But yes, of course, it is available. It is, if it is available and the person can get it done from a friend or someplace, yes, why not? It always adds to your information.
Yes.
Sure.
Agree. Any other thoughts before we go on to the next question? I just felt that this is a critical point. And on
Chitra,
9th,
can I just chip in?
Yes, Partha.
Yeah, Chitra, here, your question was a new practitioner doing his first, say, 10 phakic IOLs. For a new practitioner going on to the phakic IOL scenario is again a very, very important task for him to do correctly and as accurately as possible. Once he's in a stature where he has done 50, 100, he can twiggle with the numbers 270 microns and 200, the AC depth of 270 or AC depth of 280, 2.8. All these things can be twiggled with. But for the new beginner, I would definitely say a topography as well as all the parameters and rechecking the white to white with the digital, correlating it either with the pentacam or with the IOL master is definitely, I would say mandatory. Because once, it comes to Kamal Kapoor's, status, he can definitely have a lot of understanding of it. But in the earlier stages, it should be mandatory for all of us to follow the total guidelines.
Yes, I agree totally.
Ma'am, can I ask a question?
Yes, Naga.
Yes, sorry, my video is not working. Really sorry to everyone. Just a question. I want to present a case where, see, for example, you have an IOL master reading, which the technician or the optometrist has done, which is 11.7. The digital caliper, considering we ourselves have done, because I really believe that the operating surgeon should do it, is say 11.3. And the UBM, which again is done by a second technician, is say 11.9. So 11.7, 11.3, 11.9, which, and obviously we know that all of these three will not correlate. Now, which of these will you actually take and which will you put into the calculator is the first question. And along with this, once you put into this, I'll just complete the second part of this question. If the company gives you say 12.6 or 13.2, see, because there is a cutoff at one point where it shifts from 12.6 to straight 13.2 in ICL, unlike in IPCL where we have 0.25 increments. So here the difference is almost of 700 microns, which makes a great difference in your world. So my question to all the esteemed panelists is, in the first case, which would you take between 11.7, 11.3, 11.9? And how would you, because every time the company is not necessarily right, even though they use their nomogram. So many times we have found that we need to tweak it a little bit. Yes, please.
Can I come in?
Yes.
Okay, I think, Anaga, this is a fantastic question. I encounter this when I train people and my optoms and my doctors to do phakic IOLs in all the centers. One thing is, if the variation is more than 0.2, even with the same observer, let's keep the other observers out or a different system. We have a system that a second observer comes in and it's a double blind, in the sense the second observer does not know what is the reading on the caliper done by the previous one. Because believe me, if I tell you what reading I got, subconsciously you will try and figure that out on a digital caliper. That's one of my personal observations. So if I did not tell my optoms or my surgeons what reading the earlier surgeon had or the earlier optom had, I tend to get a more accurate and a realistic view, number one. Number two, I have realized that apart from Pentacam, Tommy, IOL Masters, somehow in my institutions, we get fantastic accuracy on white to white on my Cirrus. We started using Cirrus for calculation of white to white, and our accuracies are 96%. But what we do is we use a manual edit mode, which the machine gives us an edge. So this is where I feel technology really steps in. Anaga, like your case, 11.3, 11.6, and 11.9. I would put this on Cirrus, and the Cirrus has a machine called manual edit. So you can zoom in on the picture, manually move on an infrared image on the perfect mid-limbal line on one edge, and then similarly on the other, and then see whether your reading varies. So you get two readings, one which the machine did by itself and one which you did on a manual edit. So over time, you realize that the manual edit extremely, whenever there's an issue with the other three readings, the patient is put on the manual edit mode, and usually we go in more towards the manual edit, the reading which is nearer to the manual edit. So by now, by default, most of our calculations are based on our SHREYAS outcomes, and we're getting fantastic results.
So now the problem is there are just too many machines. So if we have the UBM, the Pentacam, the IOL master now, it's difficult to have both Pentacam as
I'll
well
answer
as
that question also, Anaga. In
anybody
fact,
who can give. It
So
becomes so
oversimplify
difficult to
the
have
answer,
everything,
ma'am.
and
my
more the
previous-
number of measurements, the more confused you can get.
Excellent.
So,
I'll simplify it. If you have a decent autorefractive keratometer, which gives you a very good infrared image and it has a built-in pupillometer, this will work, believe me. In my secondary or smaller centers where I have not kept these SHREYAS or these pentacams, this is how we work for the basic screening. So we've also tabulated the calculations on an autorefractive keratometer, measuring the mid-limbal line white to white, and the readings are sent to us and the patient comes to the secondary center. We find that mostly these corroborate with that. So in case a person does not have access to a high-end machine and he just wants to have an idea, so this comes in handy. Suppose you do a white to white on your pentacam, on your caliper, and some other machine, and you have varying readings. So just an autorefractive keratometer with a pupillometer built in, provided it gives you a very clear infrared image, is going to settle the decision between these extreme readings. It's very helpful.
Shreyash, you wanted to add something?
No, I mean, that's the basis of the study that we did, and even from experience from a lot of cases. Unlike what Dr. Anaga said, in most, I think, multi-surgeon practices, larger volume practices, it's very, very rare that the operating surgeon actually measures the white to white. It's usually being measured by a trained or a skilled optometrist. So there are variations, no doubt there are variations, and that is why we want to look at alternatives from just the digital caliper measurement alone. To oversimplify the statement, digital caliper, if you have to have an alternate first measurement, it would be preferably a Scheimpflug device, followed by an optical biometer. Optical biometer, while reliable, like I showed in all my slides, the mean values of different studies will be similar, but it does throw out outliers. And those outliers is where you may get caught. There are fewer outliers with the Scheimpflug than compared to the optical biometers. And you would probably want to choose more in favor of the Scheimpflug. And of course, if you want to be a little more fancy, linear regression analysis work.
Now,
I
has
think, the basic difference between a Scheimpflug device and an optical biometer is the optical biometer measures sulcus to sulcus. While what we want with our actual measurement, what we want is mid-limbus to mid-limbus. So basically, practically, of course, Shreyash has done a detailed study, but practically what we do is use either a Topolyser or a Pentacam or a SHREYAS device, depending on the center where what is available. Make digital calipers the basic instrument and get the measurement and compare the two. If these two tally together, then go with the measurement. Obviously, we have tried UBM, but as was pointed out, it's very often very difficult to even identify exactly which is the sulcus, because that's the kind of clarity that you get with these instruments. So if you give two different observers or the same observer to take a measurement, you will get two different measurements. So we have practically given up using UBM for this, though because the lens rests in the sulcus, you would think that's the right way to go. In our hands, practically what seems to work is a good one-year calipers measurement with digital calipers measurement taken under the operating microscope, compared with a Scheimpflug device. And if these two things tally, most often it works out well.
Good. So
can I have a quick
just one point I wanted to make here.
Yes, Rajesh.
Yeah, so I completely agree with what Dr. Ramamurthy has said, that ultimately, see, if you go and measure sulcus to sulcus, then your size of the lens should be exactly the diameter of what you have measured.
Absolutely.
Whereas if you look at the nomogram varies with the white to white and the anterior chamber depth. That means the deeper you are, the lens size becomes bigger. So it takes into consideration. So for me, if I had the situation where what Anaga has posed, I would rely definitely on my caliper measurement. I would go back and I would measure it again, especially if a patient is a contact lens wearer. Sometimes they can have ill-defined limbus. So you have to first go and, remeasure, taking into account what defines the mid-limbus. and then compare it with one of the shine plug. And usually if I do, I have found on my series, there is a value that comes in, it's called HPID, horizontal visible iris diameter. And somehow that seems to correlate very well with the caliper measurement that we do. And I take into account that in such a case, when you have 11.3, it's better to use that because the size of the ICL that would be given will prevent excessive vaulting. Whereas if you try to go with the higher measurement, you will end up with a vault more than 800, 900 and a shallow anterior chamber.
Yes, makes
I was
sense.
just going to make that same point, sir. It's actually white to white or HVID, which is what is measured across devices, and HVID tends to be slightly more than the white to white for measurement.
Now, has the size?
Do you have a multiplication factor which can be used for the optimizing the different instruments? I'm asking you, Suresh. I mean, based on.
No,
sorry,
that's what it's not a multiplication factor alone. I mean, it's a regression equation. It has a constant and a variable component. So applying that regression equation from the large data set that we took of about 600-700 measurements, we arrived at a linear regression analysis, which enhanced the accuracy, enhanced the agreement value, enhanced the R square. So while we had only 66% agreement of within a variation of 0.2 millimeter between pentacam and digital caliper, using a linear regression analysis, we were able to improve it from 66 to 98%. So it just increased, reduced the outliers, improved the agreement between the various measurements.
Now we go on to a little variation in this. Has the sizing of phakic IOL changed with a central hole? Like if a patient has 1,000 micron vault or 100 micron vault, when would you decide on an exchange? Would you exchange it if the patient is still comfortable? I want, whom do I ask? Shall I ask Dr. Purendra Bhasin? Dr. Purendra Bhasin, are you there?
Okay.
Please unmute.
I'll answer.
Yes,
Unmute.
yes.
No, Dr. Bhasin sir is muted. So please unmute.
Yes, sir.
Yeah.
Can you repeat the question, please?
Now, if the patient, since we have a central hole in our phakic IOLs, if a patient has 1,000 micron vault or 100 micron vault, when would you decide it's time to exchange these lenses? And if the patient is comfortable?
Yeah. So one is when the vault is very high and there is a rise in intraocular pressure, there is occlusion of the angle of the anterior chamber when we see it like this. And then we have to plan for explantation of the IOL. And if it is more than 900 or 1,000, then we ask the patient to come for follow-up periodically. And if we find that there is there is a rise in intraocular pressure and angle occlusion is there, then we will definitely explant it. Otherwise, we can, if it is around 900 or 800 or 700, then we can leave it and we can ask the patient to come for follow-up every 3 months.
Yes, doing a serial gonioscopy makes sense. Partha,
Yeah, so that was the first part of the question. I totally agree with what Purendra said. And it is the angle that has to be measured time and again, and a close follow-up. So to assure ourselves that the angle is not occluded, provided, of course, the IOP is not rising. If the IOP is rising, then it is a case where you have to explant it. The other
Sorry, may I put in a comment here?
I would also say some pigment, if you see pigment on the lens.
Yeah.
The other part of the question was 100 microns of vault. Now, these cases again have to be watched for the cataractus change to take place. And with these ICLs, I've been following up maybe a couple of ICLs over quite some time, about 100, 125 microns of vault. They have not yet developed cataract. This is nearly 2 years, 3 years now. And it is, there should be, not a hurry to explant these lenses if it is carrying on. If the patient has not developed cataractus changes, if the patient vision is fine, these patients can be carried on with close follow-up.
Yes. Yes.
Can I add one thing?
Can I add something?
Yeah, can I?
Yes, Dr. Tell me.
Yeah, but in 100 micron vault, what I do is I dilate people fully and do pentacam and Scheimpflug imaging and see the vault which is equal, because sometimes what I have seen is which the low vault there is a peripheral sagging of the eye lens. So it touches in the mid periphery. The lens touches the crystalline lens in mid periphery. If it is not touching, if the vault is further reduced in the mid periphery, then I will explant it, and we will see for the development of cataract. If there is anterior capsular cataract is there, then we explant it. And with the centraflow newer lenses, the chances of development of cataract even at low vault of 100 or 125 or 150 is very rare. But peripheral sagging of the lens, I always see after dilatation of the pupil of the ICL or IPCL.
Dr. Sanjay Chaudhary,
yeah. So first, the issue of a flat vault, that means a very low vault. We have to know that ICL has a natural vault of about 85 microns, which means even if it is totally flat on the crystalline lens, it will still have a vault of 85 microns. Now, the question is that if it is that flat, then we explant it or not explant it. Our experience and knowledge of whatever is discussed on platform is that as long as the aqueous is flowing, there is no aqueous stasis, we wait and watch. And we have watched these cases for the last 6-7 years, and they have not developed any cataract. And this is what the literature is saying now all over the place, that with the central hold, the chances of cataracts are minimal. It does not mean that somebody somewhere will not land up in a cataract. But in the meantime, it is better to wait and watch, because the likelihood of developing cataract is getting very remote now. Now, in the situation of a very high vault, 1000 vault is actually still not a very high vault. It is high, but still not a very high vault. 1300, 1400 is getting higher. Now, if you have a high vault, then you have to see what is the IOP, keep a close watch on it. And if it is really very shallow, the looks really doesn't look nice. That is all over. And sometimes you even find that the iris touches the endothelium at one point, or the rub of the lens on the pigment epithelium of the iris is so strong that you start getting ectropion of the uveal tissue. It is always better to explant these lenses, because once in a while it is going to give you trouble. So a good vault, but a good fairly acceptable depth of the anterior chamber over the ICL, leave it as such. Nasty looking, take it out.
Dr. Kamal, you wanted to say something.
Yeah, I think I would tend to agree with all the previous people, but also have my own take on it. Shallow vault, if it's a toric lens, I would explant it, because sooner or later it will rotate. Take it from me, sooner or later it will rotate. And number one, my second condition would be if I have a patient who I cannot keep on regular follow-up. Believe me, there could be patients like that. I would explant shallow vault. So toric IOLs and a patient who cannot be in a regular follow-up for a shallow vault, I would explant. Number one, even with the IPCL as it's ICL, the inherent vault is 350, but still at 350, there could be chances if the lens size is higher. I'm talking about the lens size. So what we do is before we do the phakic IOL, we calculate the lens size. So then this lens could be touching at the periphery, and the contact point, even if there is a centraflow, the contact point with the mechanical iteration can cause a cataract. So I agree with what Dr. Purinder said. Dilate the patient, do a Scheimpflug imaging, see whether the periphery is touching or not. So if it's a toric lens, periphery is not touching. If it's non-toric, periphery is not touching, I have a patient on follow-up, I would not explant. If it is a toric lens, I cannot have the patient on follow-up. And on dilatation, I see a possibility of touch and an pigment on the IOL. I would explant. That is my experience. Very huge number of lenses. That I would say that. Now, if in case it's a high vault, I agree with Dr. Sanjay. I have patients who are 1200, 1300, 1400. I'm following them up. They are great. So what I look for is a plateau of iris coming up. Number two, if the pupil is accidentally dilated on Tropica Cell Plus and the iris is getting stuck, getting back to place, I would explant. I do an gonioscopy, and again, I look for pigments. If these things are there, I would explant, but if they're all fine, I would not explant even at 1300.
So does it make it important for all of us to think that we should also measure the lens rise, and it has an impact on the sizing of the phakic IOL? Shreyash, would you want to add?
I feel especially when you have a lower wall, that's when the lens rise really comes in fast. That's very important.
Yes, Shreyash, because some of these were on sizing of IOL. Do you have anything to add? Because there have been wonderful discussions now.
Lens rise is definitely important. The only unfortunate thing is we don't know at what value of lens rise that we need to change the size of lens that we choose. That cutoff is not clearly established. So at least it's still not followed in any of the nomograms. We have lens rise measurements. And as Dr. Kamal pointed out, the obvious that in a shallow vault, lens rise becomes even more important. That's definitely taken.
Ma'am, Swapna here. If I may just put in a comment, my video is not working again, like Anaga's. So actually, I had tried to do a study on that, and we tried to see if the lens rise is significant as far as sizing of the IOL is concerned, because just to prevent, a low vault or a high vault. And we went to STAR with it, and I had talked to one of their clinical applications people when we had gone for one of their conferences abroad, and she said that they had already done a study, and they found that lens rise is not a significant. I don't have details of the study, but STAR has, for its ICL, already conducted research on the factor that lens rise may be an important factor, and they have found that it doesn't affect the sizing of the IOL. That is why they have not revised their nomogram and then continue to use the same one.
We are going to stop the discussion here because we need to learn a lot more from other speakers.